Is it clear? The primary glycated bodies when they bind with those proteins. Is it clear? Now, those proteins or those primary glycated proteins are also called the sheath bodies. Now, those proteins now are going to bind now with the connective tissues at the level of the endothelium. Is it clear? They bind with the connective tissue at the level of the endothelium to produce the secondary glycated body. Is it clear? To produce the secondary glycated body. Now, the secondary glycated bodies are now the one that are going to erode the endothelium. So they just erode the endothelium. You can just think as if they say you need to know that what normally if you just place glucose, you place sugar inside a cup, you put it hyper concentrated, that sugar is going to produce pellets. You have to think as if those pellets are the one that are destroying the endothelial membrane. Is it clear? So those are the points that you have. I want just to put in mind. Now, this one was involved with the macrovascular complications. Is it clear? Macrovascular complications. So you are going to, for the macrovascular complication, you're going to have the major pathophysiology is atherosclerosis, and that atherosclerosis occur by the non-enzymatic pathway. Is it clear? Now you need to know that when you have the non-enzymatic pathway resulting to the atherosclerosis, the atherosclerosis only majorly involve the big vessels, and those big vessels are acpic mnemonics. Is it clear? You have the acpic mnemonics. A for the abdominal aorta, so it is the abdominal aorta that is going to be atherosclerosis. C for the coronary artery, so the patient is going to suffer of diabetes, going to suffer of coronary heart disease. P is going to be for popliteal artery. Is it clear? So the patients that have diabetes mellitus also suffer of peripheral vascular disease. I is for IC is for the internal carotid. So the patient that suffer for this is also going to have a stroke, internal carotid artery. So the patient that suffer from diabetes mellitus is also going to have a stroke as complication. So those are the different mnemonics. Now, how do you visualize an abdominal aorta, abdominal atherosclerosis? Usually, abdominal atherosclerosis can only be visualized if there is involvement of the renal arteries. Is it clear? So abdominal atherosclerosis can only be visualized if there is involvement of the renal arteries, or you can directly visualize that shows. So in abdominal atherosclerosis, you are going to hear abdominal breaths. Is it clear? Not to be confused with the bowel sounds. So you're going to hear abdominal breaths, meaning that what you're going to hear sounds like shh, 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 shh at the level of the abdominal aorta. And the abdominal aorta, you need to know that this is the chest, this is the abdomen here. The abdominal aorta slightly come on the left of the umbilicus. Is it clear? And at the level of the umbilicus, it divides into two, which are the renal arteries. Is it clear? It divides into two. It slightly comes on the left and it divides into two like that. So you place your stethoscope here, you're going to hear shh, 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 shh. As you said, that's for abdominal atherosclerosis, for abdominal breaths. Now, if you also have renal breaths, it means that there is renal atherosclerosis or there is renal stenosis. Is it clear? So those are the different things that you have to do on your physical examination for you to identify those abdominal atherosclerosis. Now, for the coronary artery, how can you visualize coronary atherosclerosis? Here, you need to know that you cannot hear any coronary breaths. It's not possible. Is it clear? Because what you're going to hear is the heart sounds and not the breath. So now, so you cannot hear any coronary breath. The only presentation the patient is going to have with coronary artery disease, is it clear? A coronary artery disease, the patient is going to present with an ischemic chest pain. Is it clear? The patient is going to present with an ischemic chest pain. And how does ischemic chest pain present? Ischemic chest pain is a compressive type of chest pain. Is it clear? It's a compressive type of chest pain, excruciating, and so it's an excruciating, compressing pain. Is it clear? So excruciating, compressing pain that is aggravated by effort and which is relieved by rest. Usually, those are ischemic chest pain. And when it arrives to myocardial infarction, it's no more relieved by rest. For myocardial infarction, the specific characteristic is going to be more than 20 minutes. Is it clear? In angina pectoris, generally specific characteristic is less than 5 to 15 minutes, while in unstable angina is between 5 to 15 minutes. So those are the different things that you have to put in mind. Now, the next one is the internal carotid. For the internal carotid atherosclerosis, you need to auscultate at the level of the carotid, where you're going to hear carotid breaths. The carotid at the level of the neck, when you have in front of the sternocleidomastoid muscles, you have the carotid arteries. Is it clear? You auscultate the carotid artery where if you're going to hear for breaths. Is it clear? You can hear sounds at the level of the carotid artery, and not to be confused with the respiratory sounds coming from the trachea. Is it clear? So those are the different things that you have to put in mind. Now, after working with the atherosclerosis, you need to know that what we have now, the microvascular complication. Is it clear? Now, for the microvascular complication, the pathophysiology for that is going to be the enzymatic pathway. Is it clear? It's now the enzymatic pathway. Now, what results in the enzymatic pathway? In the enzymatic pathway, you need to know that what you have the conversion of glucose. You normally have the conversion of glucose to sorbitol by using the enzyme aldoreductase. Is it clear? So you normally have the conversion from glucose to sorbitol by using the enzyme aldoreductase. Is it clear? Now, what happens is that what, since there is excessive, normally there is not excessive glucose inside the body. Is it clear? But what happens is that since there is excessive glucose inside the body, there is excessive glucose inside the body. So this enzyme now aldoreductase is now going to convert that excessive glucose now to produce sorbitol. Is it clear? Since there is excessive glucose in the, normally there is not excessive glucose. Since there is excessive glucose in the body, this enzyme is going to convert it to sorbitol, and now sorbitol is what results now to the microvascular complication and other complications. Is it clear? Now, so if sorbitol, when sorbitol accumulate at the level of the small vessels, it produces what is called a high linosis at the level of the small vessels. That is what is going to result now to retinopathy. We call diabetic retinopathy, because the retinal arteries are small arteries. When sorbitol accumulate there, it results to high linosis. Is it clear? Accumulation of those is going to result to high linosis. So it's going to result to a microvascular complication, which is diabetic retinopathy. So also at the level of